Good morning. Thank you all for coming. My name is Allison Keeler. I am a nurse with Hospice with Confluence Health. I've been there for 10 years doing hospice care. I've been in different roles, so hospice intake, where I'll go be the first one in the home to talk about hospice services. I've been the educator, and now I'm back seeing patients doing the intake role again, the admissions role. So I'm very grateful to have this opportunity to be here and speak with you about palliative care and hospice and interact. There's plenty of time for questions or comments, so please make sure to jump in if there's something you'd like to dialogue about or something I say that doesn't quite make sense if you want some clarification. And we're going to start with palliative care. So has anyone in this room had experience with palliative care? Okay, some experience there. So palliative care is really specialized care. So palliative care is for anybody who has a serious illness, to help relieve the stress and symptoms and burdens that illness has. Palliative care does not take away regular medical care. That all stays the same. Palliative care is in addition to that. So it's an extra layer of support, an extra cheerleader on the team, a team member, to hopefully the goal would be to cohesively bring the medical team together. So often folks with chronic illnesses are seeing many different specialists. They might go to their heart doctor, the lung doctor, their primary care physician, the kidney doctor. And so there's all these fragmented pieces of care. If you think about, 50 years ago, 60, 70 years ago, you might just have been seeing one provider for many of these things. But now we have all these specialized areas, so we have a special area with palliative care as well. They also support families, so conversations with family members regarding illness, and they do that through many different ways, and I'll get to that. They are experts in pain and symptom management, so they can, message the doctor and say, gosh, Mrs. Smith is really struggling with pain. I see that this is a plan for her. Could you consider addressing this? They also have physicians on the palliative care team and mid-level providers, so nurse practitioners, who can assist with that as well. And palliative care is provided concurrently with life-prolonging care. So one of the misconceptions, I have this on another slide, with palliative care is it's like hospice. Well, it's not. So people still get their curative treatments while they're on palliative care. So cancer patients might have palliative care support, but they're also still getting those cancer treatments, going to the ER if they need to, and hospitalized if they need to. So interprofessional palliative care. We have, at Confluence Health, we have a social worker on our team. There are nurses, there are 2 nurse practitioners, and I believe we now have 2 physicians. Some larger medical organizations have a chaplain on their palliative care team. They might have a physical therapist, an occupational therapist. We're a little bit more limited with that, but we like to say interprofessional because as a nurse, I can't always meet those psycho-emotional needs somebody might have, and so that would be bringing in the social worker, or if there was caregiving needs. So what are the resources in the community to help guide people that way? It's very person-centered care, meaning it's based on values and goals. So figuring out what's important to the person. What is a good day like for them? What are their hopes for the future? What are their goals for treatment? And what do they value the most? And it's not just the person as well, it's also, again, with that person-centered care, it's the loved ones that are there supporting them too. Facilitating family conversations, right? Mrs. Smith might tell a provider, my husband doesn't know I'm this sick. Palliative care is a great extra support to say, can we have a joint visit together? Would that be okay? So we can talk about this. Palliative care also works to help one understand their illness and the impact of that. So asking, what has the doctor told you? What do you know? What can I help with? You figuring out what gaps can I fill for you? And then the overall overreaching the overreaching theme would be to improve quality of life with all those interventions. Any questions so far? Okay. We know there's a ton of data out there that early integration of palliative care when somebody has a serious illness equals increased satisfaction with overall outcomes with the medical care system and one's journey. Palliative care encourages autonomy and advocacy. So we want the person to be the captain of their ship, so to speak, right? The medical system should not be the captain of your ship. You should be the captain of your ship. You know, we should be along as a navigator to help you navigate through the journey. And then advocating for yourself, like these are what you should ask your heart doctor. Gosh, I'm hearing you say that you need more information. You know, this is what I'm going to suggest you ask. Improving quality of life, you'll see this even in the hospice stuff. It's such a big thing, it's a big deal, right? To have that quality of life. Improving the coordination of care, provide information on advanced care planning, advanced directives. That's so important. That's for anybody over the age of 18. You don't have to have a serious illness to have advanced directives. So that's naming the person that you would want to make decisions for you in a medical situation if you couldn't speak for yourself. Washington State has a hierarchy of what that looks like. So let's say if I didn't have advanced directives, it automatically defaults to my husband. If something happened to my husband and I at the same time and he couldn't speak for me, the next step would default to both of my children, where they would both have to come to an agreement as to what my wishes would be. So advanced care planning is so important because you also outline your values and goals on there of what you would want, what's important to you. And then I already mentioned this, connection to community resources through palliative care. Barriers to palliative care. Well, palliative care is a new subset of medicine in a sense, and can be thought of by folks. I've had lots of these conversations like hospice, right? Oh, I'm not ready for that. I don't need that. Or I'm not gonna give up. Instead of looking at palliative care as it's a ball of hope, it's help. Cultural and social barriers. We were just discussing over here about how we do such a good job talking about what to expect when you're expecting. I love how you brought that up when mommies have babies. You know, there's support groups, there's talk, there's all of that. But on the other end of the spectrum, there's not really a lot out there or dialoguing. My mother-in-law is she's early 80s, she's extremely healthy, but she doesn't want to talk about her advanced care plan. That's okay, that's autonomy, right? That's where I go back, I'm like, that's okay, that's your choice. But she never had those conversations with her parents, and I'm gonna think that maybe it just wasn't passed on. It's not a cultural connection that they have. Lack of resources. So again, it's a specialized form of medicine. Having trained clinicians to be able to navigate serious conversations with people. It's a whole different area of medicine. It's not like prescribing a water pill or a new heart pill. It's navigating the system with conversations. And then rural access. So you already have more of a limited supply of clinicians, limited budgets by organizations, because it's not a real, how do I say this nicely, there's money in treating people's illnesses, right? Where palliative care is not necessarily a test or a lab or imaging. It's extra support. And folks that live in outlying areas, if they have a serious illness, can imagine that would be very difficult for them to have one more appointment that they have to go in and meet with somebody. Our palliative care team here does telehealth, and they also do in-home visits as well. So they see people in the clinic, in their home, or even sometimes facilities, and via phone and video. Okay, before we move on to the next subject, any thoughts on that or questions? Yes?
Can you name some of the other illnesses outside of cancer that
Sure.
might be sort of, oh, yeah, it would cover if it's MS, or is it myasthenia gravis, or, you know, some of the other range of what could be a
Absolutely, all of the above. So any serious illness at all. So your heart failure, lung problems, dementias, Parkinson's, liver, kidneys, any serious illness that requires interventions, and no age limit to it at all. So MS, yes.
My husband had a stroke, but the follow-up care was really excellent, and we had I believe she was a social worker. Well, anyway, she came once a month for a whole year.
Was that palliative care here? And was it palliative care here?
I would assume so.
Okay. Was her name Tamara? Does that sound familiar? No. Okay. Yeah, that's something that they do. They get a regular cadence of visits with folks, with check-ins and help support.
Yeah, palliative care can start, but it can also end when the situation is changed.
Absolutely,
Yeah.
absolutely. Thank you for bringing that up. That's a great point.
I have a question. This is another one back there. So does insurance cover it?
Insurance does cover palliative care. Yes.
Through
Well, I'm going to speak mostly to Medicare.
Medicare?
Yeah, Medicare, private insurances do as well, to my knowledge. There's always those random things,
Yeah, no,
but.
I was just curious if
Yeah.
Medicare was the primary
Yep.
care. Okay.
And Pastor Debbie?
Is long COVID covered at this point? Is it?
That's a great question. I think if it's a serious illness that requires symptom management needs and coordination, then I would say yes. Yeah.
Well, I was actually going to long COVID, but also long COVID mixed with age.
Kind of like failure to thrive
Yeah,
or.
where does that land in palliative care? Because the healthiness is there.
Okay, physically health,
Yeah.
gotcha.
Yeah.
That might be, we could side discuss on that.
Okay.
If that's a personal, if there's a
Okay.
experience there.
Yeah.
And they're great to assess and see what the needs are. And it might just be education, it might just be once every 3 months, you know, based on what the individual needs are of the person.
Okay.
You said you can receive or seek this care from a hospital, or you said the clinic. What's the?
Well, if somebody, you can go in for visits for palliative care, like you're going to a doctor, you schedule a visit. When I might have been referring to when you're on palliative care, you can still have curative treatments, like going to the hospital, because hospice is a little different.
Right. You mean, if I want palliative care, who do I seek out to get it?
Who do you seek out to get it? I have a flyer right here with the phone number.
Oh.
Okay. Okay, we're going to talk a little bit about hospice. And in this room, experiences, anyone have experience of hospice? Okay, quite a bit. So the hospice philosophy is rooted in dignity and the right to die without pain and suffering. The right to live. I'm going to say live the rest of your life, right? When death happens, when you take that final breath and you're gone. So we're going to say the right to live the rest of your life, to be pain-free and your symptoms managed and supported. Hospice provides expert medical care. Again, it's a very specialized form of medical care, emotional and spiritual support, and I'll talk about the team members that help make that happen. And our support and care is going to align with what the patient's values and goals are, or their loved one. If the patient can't speak and share that for themselves, their advocate, the person on their advanced directives, who's their voice. And that's what we have to find out to make sure the care is person-centered. We're focusing on quality of life with hospice, not quantity. So we're walking the path, we're walking alongside the journey of that disease process, that person's journey. We're not there to speed it up or slow it down. We're there to be in the moment and provide support and education. And then we also you recognize that death is part of life. You know, people have been dying since the day we were born, for sure, right? Or there'd be a lot of us on this planet. You know, even back, you know, in the times of the Crusades, they used to convalesce and have places where they care for the dying. People used to die in the hospital, right? Hospitals 50, 60, 70 years ago were places where people went to die, not necessarily places where people go to get better, per se, if that makes sense. There was a lot more death in the hospital. I don't know, I'm kind of a history buff, but I like to look at the history of hospice to understand how new it is and why we're still navigating this, why we maybe don't have conversations like we should. So in 1963, a UK nurse, Cicely Saunders, came over to the US. Cicely Saunders had already started the hospice movement in the UK. And she came over and she spoke at Yale, and the dean of nursing at Yale got so invigorated by her, like, passionate about what she was sharing, that then it started to spread in the US. Elizabeth Kubler-Ross, has anybody heard of Death and Dying? Yeah. So she testified in front of the Senate on the Aging Committee, I can't remember the exact name, for the Senate. So she's bringing this now to the forefront for us. Testifies in front of the Senate, there it is right there, at a US Senate hearing, and our government or structure is kind of like, okay, well, this is an issue. We need to address this aging population, and how are we going to care for them? In 1974 was the first hospice house in the US, in Connecticut. There's just one of them by, she's not up here, but Florence Wald, who was inspired by Cicely Saunders. And then it wasn't until 1985 that we got the Medicare hospice benefit. So still pretty new if you think about it in the scheme of things. New terminology, and not much has actually changed to that Medicare benefit since then. I think that's pretty rare. I think most benefits haven't changed, so it's still about the same. So when I talk about hospice and what we provide, it's pretty much the same no matter what the insurance coverage is, but I'm going to really speak to the Medicare benefit. So somebody has to have a terminal diagnosis. So that might be that serious illness that has now become terminal, whether it can't be treated anymore, or the person doesn't want any more treatment and they want some support. Physicians usually send us a referral, or providers, I'll say providers, send us a referral. But the special part about the hospice Medicare benefit is people can refer themselves. If they qualify for hospice services, they can get it without a doctor sending in a signed referral. We are focusing on palliative management. So kind of like palliative care focuses on symptom management. There's no further hospitalizations or emergency department visits when someone comes onto hospice. And that reason is Medicare A, which covers hospitalization, turns off and turns on to hospice Medicare. And so Medicare is paying hospice to care for folks, or to provide support and medical guidance to keep them in their living situation. Now there are caveats to that. If somebody was on hospice and they fell, and let's say they got a large cut on their head and we thought they needed stitches, hospice would send them in to get the stitches and then back to their care situation. So we always say, call 911 now. The night hospice is now, when someone goes on a hospice, hospice is the 911. Hospice becomes like the medical provider, so to speak. We go to every place that people live. Nursing, skilled nursing facilities, so long-term care facilities, adult family homes, assisted living, group homes, and then of course, private homes as well. So wherever somebody resides, that's considered their home for us. 24/7 support. So there are nurses available 24/7. We have 2 nurses always on call when the office is closed that do a lot of triaging on the phone or make visits if it's a high need situation or it's something that someone can't take care of themselves. And the interdisciplinary team, which I will introduce you to right now. So hospice is kind of our services and the people involved, it's like a buffet. Like, you're always gonna get a plate and a fork, and the rest of these you can choose from. So everyone is gonna have a physician. We use the primary care provider, and then we have the hospice provider too, so they work in conjunction together. Our hospice physician is available 24/7. So it doesn't matter if it's 2 a.m. and we get a call, and let's say Mrs. Smith's pain's uncontrolled, we need something more than what we have there, that physician is right on it. They have to be available to us 24/7. Every person gets a nurse coming out. Nurses visit minimum of 1 time a week is our standard, and then more based on what the needs are. Our nurses don't provide the care. They're for probably about 45 minutes to an hour. We're there to guide the care. We're there to check the skin. How are the bowels doing? How's the pain? How's the sleeping? What equipment do you need? What can I answer for you? And how can I help guide moving forward? And then social workers, we have social workers that see our patients 1 to 3 times a month. Everybody gets a social worker. They're not required to have them, but they're amazing to provide psychosocial support, emotional support, navigate resources that are available within the community. Then we have a chaplain, spiritual support, is how I like to refer to it. It's not just a box of a denomination, it's all over the place that we recognize, within hospice there can be a lot of existential pain or spiritual pain that can happen as things are changing with the body and with even interactions and caregiving needs that you might have or might see. We have a bath aide, it's a nursing assistant that can come out a couple times a week and help with personal bathing, whether it's a bed bath or a shower. They're actually my favorite team member because they really help people feel dignified. They braid hair, they put lotion on people. Our patients love them. And I do too. I think that it's so important to maintain dignity and hygiene if that's what the person would like. We have a bereavement specialist who helps coordinate bereavement services. So that is support for grief after somebody dies. In the Medicare benefit, when somebody dies, their designated contact or loved one, sometimes it can be a couple if it needs to be, gets 13 months of bereavement support. And that support ranges for everybody. Some people, it's just a calling and a mailing. Some people come to the support groups, all the way up to in-person counseling. And so, if the designated bereavement contact didn't live in this area, as a hospice, we're required to find them counseling services where they reside. Yeah, Medicare did a pretty good job, I think, with this benefit. And then we also have our amazing volunteers. So our volunteers cannot provide care, but they can provide respite. So if I couldn't leave my husband and he was on hospice, he couldn't be left alone, but I still needed to get groceries, make my own physician, my own appointments. Our volunteers typically, what we see, set up a reoccurring date, so to speak. So 2 hours every Tuesday from 1 to 3 type of thing, and they work that out with the people they're supporting. And they can't provide care or feed somebody, but they think they can make a sandwich and pick stuff up, paint fingernails, read stories, play games, and just generalized companionship sometimes. Any questions so far? Yeah.
I'm wondering how much of the dynamics of an increasing population of dementia and Alzheimer's, and then how that fits into the hospice model. In that, I don't even know what the question to ask is, other than hospice is, you're going to, you have a life-threatening issue, and how does that work
with dementia?
Yeah, and Alzheimer's. And are you seeing an increase in those kind of patients?
Yes.
And it'll continue?
Yes, we're living longer, and so those things are happening, yes. And Medicare has guidelines of what terminal means. So when we're submitting data, we're assessing somebody, let's say they have a dementia or Alzheimer's diagnosis, Medicare says, okay, they should check these boxes, like they should be this far into their disease process to come onto hospice services. Is that kind of what you were asking?
Well, just, yeah,
Yeah.
it's curious, I know, my brother is currently going down that road, so, I'm just wondering.
We see them on all different forms of the spectrum too, because they might have moderate cognitive impairment, so to speak, and still declining, but maybe they have heart failure too,
Yeah.
or some lung issues or kidney function issues. So putting those together paint that terminal picture. And then we have other folks that maybe all their organs are healthy and they're on for Alzheimer's and they're completely chair bound, they can't feed themselves, and they're trucking along for a long time. So it's kind of an inexact science. I'll go and talk about this now, but what we look for is we can, if they qualify, if our physician says yes, they can have hospice services, if they stabilize, we talked about this earlier, if they kind of reach this point where they're no longer declining, then we graduate them from hospice services. So hospice is a choice and they have to continue to qualify. So people can come on and off. But we do try to make it only on, that's ethically the right thing to do with using a benefit. So it's so individualized based on I've just even this week, admitted somebody with dementia who was still walking and had some incontinence but had a lot of weight loss and falls. And then on the other end of the spectrum, admitted somebody with dementia who couldn't walk, couldn't talk, and hadn't really had a lot of other things going on. So it's so individual in a sense, and it's up to the hospice provider to determine what is terminal or not. All right, that's probably a long answer to your question.
Part of what I've seen is, I see a lot of people wait a long time before enrolling in hospice. What I would suggest is maybe too long.
Right.
I've also seen a lot of physicians who are reluctant to bring up the conversation with a patient or a family because they don't want
Absolutely, they don't want to make
blowback.
Yes.
Yep. And so when I work with folks, I sort of say, I would encourage you to ask your doctor if hospice is appropriate, because I think there's nothing wrong with asking a question. If the doctor says, oh no, it's not at all appropriate, then you know that. But if you ask the question, it is appropriate, often the physician then it feels more freedom to explain why it would be appropriate without feeling like they're stepping on anybody's toes. Are there markers or indicators that you would say, this is when we encourage people to start thinking and asking if this is in order?
Yep, let me see if this will help me stay on track on the next. Oh, I won't. I'm gonna go to that slide and I'll go back. Okay. So the kind of the markers, one thing is gonna be really about what are the goals of care. If you say, gosh, I don't want my husband does not want to go back to the ER next time he falls. Next time there's trouble breathing, he does not want to go to the hospital and stay there for 2 or 3 days. That is the biggest piece. Like what do you want moving forward? So if there's like a diagnosis with Alzheimer's or lung disease or cancer, and the person says, this is getting us nowhere, is hospice, that would be the time to say, is hospice right? We just keep going back and doing the same things, and it's not giving any quality of life. It's not bringing any value to the situation. So we're looking at, this is not an exhaustive list by any means. The biggest one I see is the reduced ability to perform self-care, where that functional decline is just, is there, right? They can no longer toilet themselves, or they can't handle the mechanics of toileting, or they can't shower or dress themselves anymore. Weight loss is a big one. Not as interested in food. Doesn't taste good, withdrawing, just kind of no appetite. And then falls and infections and change in mental status. It's kind of a lump thing here. Now, people don't have to have, some people have one of these, Some people have multiple. Usually the people that wait really long might have multiple of these, and there's nothing wrong with that. It depends on, again, what the goals are for the care moving forward. But it is, I've been in, I had to look back, I've admitted almost 1,000 people to hospice, and I ran a report to see, I've been in a lot of charts. And I do see, when I'm researching to bring people on, I do see maybe opportunities to have had the conversations sooner. Because all of those people involved in the hospice team do a great job, and that's a lot of support. And the sooner you can get it, the better the outcome is. The better the process is. The whole process of end of life can be helped. Doctors refer people for hospice services when they think they have 6 months or less. But we have a lot of people that live 1 hour, 1 week, 1 month. We have people that are 1 year, 1.5 years. They graduate, they come back. So it's really, I wish I had some slides with some statistics, because these are great questions. Physicians providers get, especially long-term relationships with people, their ability to prognosticate, studies show, is pretty poor, because they really like their people. They have a great relationship. They're not necessarily looking at that long game. And I'm not making the assumption for all providers. The data's out there that shows that. So that advocacy is so important, and just asking. I mean, hospice can go out and look at the situation and say, oh gosh, not time yet. You know, our doctor, but we've got some good information, and let's tell you what that would look like for us to come back. You do lots of like consults. I do consults, you know, going out and just gathering some information, and I'll talk with our hospice doc, and they'll say, oh gosh, they're not quite there, but I wouldn't be surprised if we were back in a couple weeks.
So the palliative care, right?
Yeah.
And hospice. Is palliative care something the patient can choose? I'm ready to change doctors, no longer need a family physician, I need a palliative care, because maybe the palliative care physician or team would know more so when to talk about hospice. Family docs, that it's the same thing I think you're talking about, of if they've been seeing this person for 20 years,
Mm-hmm.
You know, it's just not talking about that.
Palliative care won't take over as a primary provider.
Okay.
They actually did at Confluence for a while, but they had to scale that back because it wasn't sustainable. But you can ask for a palliative care referral. You know, these are all part of everybody's benefits. You know, that's an advocacy of saying, gosh, I love you, you're my favorite provider, but I need some more support, and I have some more questions. So asking for that and advocating for that is really important. And Pastor Debbie, to your, I'm gonna skip ahead here because, here we go, 2022, 50% of people on hospice services lived 18 days or less. That breaks my heart, knowing that, I mean, hospice isn't for everybody, you know, it depends again what somebody's goals are, but that's such a short period of time to provide emotional care, spiritual care, you know, symptom management, whole person centered care, dignity. Yeah. And that number hasn't, the last time I had looked it up from the year before, that number it doesn't improve, unfortunately.
What is your goal, hospice's goal in there? What would you like to see?
I would love to see everybody here 84 days or less or more. You know, like I would love to see everybody get their full 6 months out of hospice services. Again, you know, providers don't have a crystal ball, and anything can happen at any time, but there's lots of different markers that we see along the way. Somebody has heart failure and lung failure, organ failure, you know, your liver, the kidneys, they're called a sawtooth. They're going up and down, up and down, up and down, up and down, and they usually die at one of those downs in the hospital because it's so unpredictable with the disease. Where somebody with a cognitive impairment, Alzheimer's, sometimes Parkinson's with Lewy body, they're a little bit more, they call them dwindling, you know, they have little changes, they might get a bladder infection, never quite come back up to where they were before, they just kind of slowly dwindle in their disease trajectory. And then cancer patients, they tend to, they might be getting treatment along this time, they're doing okay, they're stable, they start to change, and then cancer tends to go a lot quicker. So when we see those markers, you know, for cancer, it should be into treatment. I would love to, if they have a terminal cancer diagnosis, I would love to see them enrolled on hospice right there. For the organ failure folks, when they're doing this and they're like, I don't really want to go back to that hospital, I'd love to get them there.
One of the things that I think we forget about is that both hospice and palliative is support for the caregivers.
Oh, absolutely, yes.
And I think
Yep.
that we as caregivers forget that they support us.
Yeah.
And
It's
that's-
50% of what we do.
Yeah, and it's, caregivers oftentimes go before the person they're caring for because they are 24 hours care if they don't have some of this other support.
Yeah.
So I'm an advocate for caregivers, I have to tell you folks.
I appreciate you saying that. Yeah, there. When I use the word patient, I think of the whole family, as everybody involved in that situation gets the support, and that's the biggest piece and the most beautiful piece about that benefit, is it's not just focused on the person; it's everybody. So I want to share the different types of hospice care, because we don't provide the daily care. So we don't come do the daily aspects of care. I mentioned, you know, minimum of 1 time a week for a nurse, minimum. So that's here, what I'm describing. It's called routine home care. That's where we set our appointments, we come out, we give the support and the guidance. But then there's also these 3 other ones that are in the Medicare benefit that don't really get talked about, so I'd like to touch on them super briefly. This one's important for caregivers, respite. So the respite benefit is for the caregiver. Respite is when a patient is transported to a nursing level of care. We actually use the clinic hospital floor for 5 days max. Medicare benefit says intermittently, so there's no, people aren't going back to back to back to get the care, but it's for when the caregiver is exhausted and they need a break. Or maybe there's a wedding out of town and they can't take the patient with them because they're too sick to travel. Used it for cataract surgeries. The caregiver needs to get a cataract surgery, get that done. So that is a wonderful piece. I think it's quite underutilized. A lot of times the patients will say, I'm not going. Or the family member will say, oh, he wouldn't want to do that. I try to encourage it though, because it's in the benefit. If somebody's really exhausted and kind of needs to step back and be the spouse for a little bit, or the daughter, you know, to have that time. It can be healing too. General inpatient. So with hospice, we say, you know, you're not calling 911, we're not gonna send you to the hospital, but we gotta have something in place for a high emergency situation, meaning somebody has, might say cancer, and we cannot get their pain under control. We can do IVs or port, we can access a port. We have a lot of different magical things we do for pain management, but sometimes pain or agitation just is not responsive to what we're doing. So hospice can send them to the hospital to get everything managed under control with the goal of sending them back home. And I think that's important for people to know, because people are afraid. You know, they're afraid that their symptoms aren't going to be managed. And we're there to do whatever it takes. And then the last one is continuous care. And this is kind of like general inpatient. It's kind of like hospital in the home. It's where a nurse will come. We're not providing the care because somebody can't. We're doing symptom management. We're staying a little longer in the home to make sure that they become comfortable. So these, to me, these 3 are really important to know. Like, we're caring for the caregiver, and we're making sure that we have things in place to care for the person for symptoms. I think we've talked about a lot of this already, but there's a couple on here that I want to mention. Under benefits is equipment, so we provide all equipment. Hospice pays for all of it. You deliver it, pick it up. So it's pretty standard equipment, but if somebody needs, like if they have dementia and they can't sit in their wheelchair anymore, we get them a tilt in space, so wheelchair that goes back. That's important to a lot of people who maybe can't afford things, or maybe their doctor says you don't qualify for oxygen. With hospice, we just get them oxygen if that's what they want. I've had many folks just like melt because they're so happy to have oxygen. That's heartbreaking, but I do understand that there's rules for a reason, but that has been very important for people. Close monitoring of preventable complications. So hospice does not mean do not treat. We're still looking, like, is there a bladder infection? You might call and say, Dad's acting a little funny. I don't know what's going on. You know, that people live longer with hospice than without. I say that because you can Google it and it's true. It's because we're going out and we're staying on top of those things, and you have somebody to call 24/7 that can come out. You know, like if I was on call and you called and said, Dad's acting a little funny, I'd ask a lot more questions. I'd say, okay, we're gonna get a nurse out there tomorrow. Maybe we get a urine sample. Maybe we're concerned about a respiratory infection. So we are still treating those things. We're just not using IVs or invasive medical testing or procedures. Medications, that's a big one for people. We provide the medications, so we pay for the medicines. People aren't charged as long as it is related to their hospice diagnosis and comfort. There are, because there's always new drugs coming out on the market, there are some medications that are cost prohibitive and hospice cannot cover them, some of the new ones. But our physicians would recommend a substitute for that, something similar. Barriers to hospice. So many wonderful things, but there's some barriers where there's no one to help provide care. Someone might live alone. We very rarely do not admit somebody for not having a caregiver. When we've not admitted somebody, it's been because they need care now. And they're stuck in their chair. I'm here for hospice to get them started, and I'm not doing them any justice by saying don't call 911 when we're not going to come out and help them change and clean themselves up every day, multiple times a day. Lack of previous conversations from providers. Thank you for bringing that up. That is a barrier. It can be very difficult to be the first one in the door, and maybe a message was sent, I see this a lot, sent to the physician like, Bob's not doing so well, and the doctor says, okay, I think it's time for hospice on my chart. And then here comes a hospice referral. And those conversations haven't happened. We're good at having, we could do them, but it's more beneficial if it happens a little further upstream. Again, short time on hospice services, we talked about that. That's a barrier to good care. You got a lot to do and there's a lot going on. It's really hard to get people everything you want them to have and experience to have in a very short period of time. And then qualifying or continuing to qualify. So Medicare is pretty stringent, or they have the directive. If somebody over time is they're on hospice and they're not showing decline, we're not seeing that, and decline would be falls, infections, heart medicines maybe needing change to manage fluctuating weight, intake not changing, and so they're just kind of cruising along, we might have to graduate them from hospice services. So Medicare always requires us to gather decline, information on decline. Okay, this is my last slide pretty much. So I like to talk about the misconceptions of hospice services. I hear these things frequently in the home. One thing I hear is hospice came in and they're stopping all the meds, or they did that. They stopped all my dad's medications and then he died. We're not there to take anything away. Our doctors are going to review the medicines and have some suggestions because the person's at a different place than they were maybe 6 months or a year ago or 2 years ago when those medicines were started. Maybe they're not eating very much. say save your swallow for a brownie, not for, I mean, I love my vitamin C, but save your swallow for a brownie. So our doctors will review those medications and have some suggestions. Of course, that is always up to the person and, or their designated decision maker if they can't make that decision. There's a lot of people, and understandably so, afraid of opioids, so pain medications, narcotics that we use. And they think hospice is gonna come in and we're just gonna start with the medicines. We do have pretty extensive orders that we can do for pain medicine if it's needed, or we use pain medicine for trouble breathing as well. But the dose we start out with is equal to half of a pain pill. It's because we use liquid morphine. I know that that can be scary because if you get, like I had shoulder surgery, they did not send me home with a bottle of liquid morphine, right? Like you're not gonna know what it is if you've never had it. So the dose we use is equal to half of a pain pill. That's where we start, and then we can go higher if we need to. Misconceptions that we're gonna pull away food and fluids. We don't do IV fluids in the home. We provide education. We have written education that we always bring out to the home about why we don't. And our hospice philosophy is really rooted in offer and not force. Because eating and drinking is culturally something we look at as comforting, right? Somebody doesn't feel good, what do? Take them food, or they're not doing well. But when somebody's having body changes over time, their body's not processing the food and the fluids the same way. So it's always just offering. That's when we say offer, but not force. And the daily physical care, I talked about that. It's so heartbreaking to go into a home and they think you're gonna be there and provide that care when that's not part of the benefit. Not that we don't want to, it's just not part of the benefit. And then giving up, that we're coming in with hospice, we're just gonna give up. No, we're still gonna we can have hope. It's whatever somebody wants and needs from us. And the hope might be, I hope for more quality time. I hope for better days. I hope for my symptoms to be managed so I can watch the ball game. I hope to be able to see my granddaughter born. And those are all those goals. That's what we need to know. That's what we ask, because that's our hope too. And ER is the word is downstream. Sometimes ER is the last provider that people see before they go home, or they're too sick then to get to their doctor's office. They can't physically get in, or their time is so short. Pastor Debbie?
A couple things. One, I think my hope with all of the workshops is that we see you don't have to do it alone. I think our tendency is to just sort of accept that aging and dying is hard, and so we're just gonna suck up the hard. And sometimes in doing the hard, we don't mean to isolate, but it becomes so hard that it's hard to ask for help. But when it feels hard all the time, and it feels like it should not be this hard or just is hard, know that there is help. Generally, there's somebody who should be able to come alongside, whether it's aging and adult care, or whether it's somebody with planning, or whether there's legal help, or whatever it might be, or even if it's just the church, so to speak. Often the church, as the body, can come alongside and help with the hard. Sometimes where we may not be eligible for respite through one of those agencies, somebody from the church could come and sit with your loved one, or somebody from the church could go get groceries, or somebody from the church could companion you somewhere. And so knowing that when it gets hard, there is more help than we often know, unless we're really well versed across the disciplines. My questions, I have two questions. One, is there a hospice house locally? And two, can you reiterate for us, we've heard it a little bit with aging and adult care when they were here, but what the overlap can be with aging and adult care, what you provide versus what they might be able to provide with supplies or respite or additional helps along the way.
Okay, yeah, we do not have a hospice house here. I was actually part of one of my volunteer group I've been with for many years, had met, there was a local hospice group. I know it was Kay Sparks and Dr. Notter, like a lot of heavy hitter community folks, and found out that it's millions of dollars to do a startup. You know, it has to be like a mini hospital, essentially, all the same equipment. And hospice house numbers are going down in the US. And I think some of that has to do with symptom management, doing well in the home, like getting people managed well, symptom-wise in the home. So if somebody qualified though theoretically for a hospice house, it actually still has the same qualification as going to the hospital with hospice support. So it's billed under the same thing for Medicare. So sorry, the answer is no, we don't, but if somebody needed that higher level for symptom management, we would send them to the hospital.
Is that the same with the inpatient care in a hospital? So that's
Or
not
meaning-
available?
Meaning,
Well, I know there's been hospice wards in the past that I've been aware of, and that's kind of gone by the wayside as well.
correct. They will do comfort care at the hospital. So sometimes we get referrals for patients, and a lot of times we get referrals for patients. They're at towards the very end of their life, and they end up dying in the hospital before they can get home and get on hospice services. So they say comfort care at the hospital is what they'll put the patient as, or the person has. And then as far as aging and adult care goes, I don't really know all of what they offer. Our social workers would be great to answer this question. We don't really interface as far as any overlap of care. Our social workers will get people connected with aging and adult care if they're for community resources. I guess I should have came to the aging and adult care one. Thank you. Okay, you're welcome. Thank you.
Thank you, Allison.
Great group. I appreciate all the questions, and you being here is a big thing. So, thank you.
Thank you.
Thank you.
Thank you.